Good evening, everybody, to our weekly University of Miami Cerebrovascular and Skull-Base Symposium. Always a pleasure. I look forward always to this part of the week. So again, this is our number 25th session today on November 5. Jacques Morcos, I'm professor and co-chair of the Department of Neurosurgery and secondary appointment in ENT. I'm director of Cerebrovascular and skull-based surgery at the University of Miami. It is always my pleasure to have the co-directors of this course, Carolina Benjamin, my partner, assistant professor, directors of our Keynes dissection lab, and Carolina specializes in brain tumor and skull-based surgery. Mike Ivan, assistant professor, director of research at the Brain Tumor Initiative, and Mike specializes in brain tumors, skull base, and epilepsy surgery, as well as my two endovascular, open vascular colleagues, Robert Stark and Eric Peterson, who run our endovascular program. This is beautiful Miami, and the two main hospitals we work at are University of Miami Hospital and Jackson Memorial Hospital. Naturally, we're a tertiary referral center for not only cerebrovascular and skull base, but many other conditions. Housekeeping instructions. Audience members, please use the Q&A box to send your questions throughout the session, and we will address them all at the end in our 20 minutes or so of discussion time at the end. We don't offer CMEs, but you can get an email confirmation that you've attended this. Please let your colleagues on social media know if you like our weekly educational offerings and let them know about it. Our two speakers today, like every week, will have 25 minutes each. I might give them a 2 or 3 minute warning before the end to make sure we have time for our panelists and for you, the audience. So we've, of course, done this like many times already. We are down here, number 25, and I will show you what's coming in the coming few weeks. But next week is actually by popular demand from you, the audience who have emailed me. You wanted sessions on complications, which I completely agree is some of the most educational sessions I've sat through as a resident, and later is listening to talks on complications. So next week is the first of 4 sessions. It will be complications in cerebrovascular surgery, and you can see our 5 speakers. It'll be a different format next week. We'll have 5 speakers, 20 minutes each. Aaron Cohen-Gadol, Greg Thompson, Siviero Agazi, Paul Camarata, and David Langer, tackling each part of cerebrovascular surgery, a different subtopic, as you can see. As you know, Mike Ivan, my partner, has also been directing a wonderful Wednesday weekly session, the Miami Global Brain Tumor Symposium. And next week, our guest is John Golfinos, the chair at NYU, a vast experience in the treatment of neurofibromatosis type 2. Very good friend of mine. I'm looking forward to listening to him next Wednesday. So please join us. And now, for the first time, too, this is now our 3rd educational offering from our department. We are going to start a weekly, when I say we, it's not me, but my colleagues, Toba Niazi and Heather McRae, pediatric neurosurgeons, will start a weekly seminar on Mondays. So if you are interested in pediatric neurosurgery, please join every Monday. The co-directors of the course are our other 2 pediatric neurosurgical partners, John Ragib, Shelley Wang. And this is their inaugural session this coming Monday, November 9, from 5 p.m. to 6 p.m. And it's on the evolving landscape of pediatric neurosurgical oncology. So again, if you have an interest in pediatric, every Monday will be a session similar to what we're doing here today or what we're doing on Wednesdays. Thank you to the team that is behind the screen here, Ingrid, Roberto, Cristina, and particularly Ignacio Escalona, who runs this webinar. This is the link to watch previously recorded sessions. We have a bunch of them by now, as you know. This is our website, and this takes you to the YouTube channel with all the previously recorded sessions. Feel free to email me. I'm also on Twitter if you need any more information. We have a departmental Instagram, departmental Twitter. Ingrid has in Menendez, who runs our educational program, that's her email there. So onto the panelists today. Great pleasure to welcome all three of them. First, Mike Chicoine, who I've known for many years now. Mike is a professor and of the Department of Neurosurgery at Washington University School of Medicine in St. Louis. Mike is a past director at large at the North American Skull Base Society. He's editor of the Skull Base portion of operative neurosurgery and many other commitments, and of course, a highly accomplished skull-based surgeon and a very good friend, and from the lineage of Harry Van Loveren and others. So Mike, it's wonderful to have you with us today. Next is Philip Theodosopoulos, obviously Greek in origin. Again, a friend of many years. Phil and I have known each other since teaching at the IRCAD in France, yearly skull base pilgrimage we've done before COVID. Both he and I missed those trips. Phil is professor and vice chair in neurosurgery and director of the skull base tumor program at UCSF in San Francisco. His residency program director, has been involved in many courses nationally and internationally. And last but not least is my colleague here from the University of Miami, from the Department of Otolaryngology, from particularly the section of rhinology, Corina Levin, assistant professor in the department. And of course, our relationship between neurosurgery and ENT is extremely close, and of course is a keystone of the skull base program. And Corina is already a rising star nationally in the North American Skull Base Society, and of course a fantastic partner in the operating room, as she will, I'm sure, share one of the slides, one of the cases later, to show a little bit how we all work together. And now on to the two speakers of the night. I didn't do this on purpose, but they both happen to be Italian. They both happen to be extremely accomplished, and of course, skull base and particularly endonasal and open skull base surgeons. Let me start with Fred Gentili, professor in the Department of Surgery, Division of Neurosurgery at the University Health Network, University of Toronto, Canada. He has been there since 1982, founding member of the North American Skull Base Society, member of the Skull Base Committee of the World Federation of Neurosurgical Societies, has a very rare distinction of holding 2 academic chairs, written extensively. And of course, this only scratches the surface. I don't want to waste too much time telling you his entire CV, but Fred, of course, has been a friend for many years. And actually, when I was president of the North American Skull Base Society, Fred was one of my 3 honored invited guests, and of course, for good reason. On to Luigi Cavallo, again, who I've met through the IRCAD teaching courses that Sébastien Frolic puts together in France. Luigi is Associate Professor of Neurosurgery in Napoli at the Federico School of Medicine. Luigi, of course, world-renowned, particularly for his endonasal work, has done more than 1,500 pituitaries, more than 500 extended endonasal approaches, written extensively, invited all over the world. Of course, Luigi is from the lineage of Paolo Capabianca, again, a giant of the field. And I'm going to stop talking, and I'm going to invite Fred to unmute himself share his screen and start his presentation. Here we go. So great pleasure to invite everybody to be part of this panel tonight.
So everybody can see my screen?
Perfect, thank you.
Okay, so thank you very much, Jacques, and I do want to congratulate you and the entire Miami group. I think you're doing an amazing job with these educational Symposium. I call them Symposiums. They're very educational. Most of my fellows watch these, and so again, thank you very much. And I know it's a lot of work. Anyways, my talk this afternoon, at least in Toronto, Poor Cavallo, it's 11 o'clock at night over there in Italy, Luigi, is the management of recurrent and giant pituitary adenomas. Now, there are a number of controversies in pituitary adenomas. The diagnostic controversy, as you know, since 2017, a WHO classification, these are now, we can no longer call these adenomas, apparently my endocrine people tell me. These are now neuroendocrine tumors. You know, there's the management of cavernous sinus involvement, the whole issue of radiotherapy, when do you do it, the indication for craniotomy, what is the best surgical approach, the management of recurrent and management of giant, which is really going to be the focus of my talk today. But just briefly, what is the best surgical approach? Well, I think we're, you know, now pretty much decided that that the endoscopic approach really is the approach of choice for these tumors. And just to show you, it's just an amazing different world with the endoscope. Here we are, the wide panoramic view that you get is just unlike anything. And I'm old enough to have done the microscopic approach so I can see it. Here we are taking this adenoma. You can see the medial wall. I'm not going to bore you with these long movies, but the medial wall of cavernous sinus bilaterally, the diaphragma has come down. You can see as we go down, here's the Doppler just showing us the carotid and the cavernous sinus. So you get a very nice removal in this type of tumor. And this patient, as you can see, post-operatively, nice resection. 13 years later, no evidence of disease progression. So I think there's no question, the endoscopic approach is really the current state of the art. And I feel there's, even though, people will say, well, where's the level 1 evidence? There really isn't, but no question in my mind that pituitary surgeon of the future has to know endoscopy, and it will become the standard of care in pituitary adenomas. Now, what is the management of recurrent pituitary adenomas? Now, this is a patient, 1990, 30 years ago, presented with macroadenoma visual complaint, and 30 years later, no evidence of recurrence, normal pituitary function. Now, we all would love to have all our patients like this, correct? Unfortunately, in my experience, this is a very much an exception. What we more like get something like this, 1993, microscopic transsphenoidal. They had a recurrence in 1997, repeat microscopic. Then in 2007, had again, disease progression. I did an endoscopic transsphenoidal. Then he had some slow growth in the cavernous sinus. We watched it, but in 2014, repeat endoscopic. And now 2015, small increase of cavernous sinus. What do you do with a case like this? Well, we'll get back to that later. So recurrent pituitary adenomas, unfortunately, they're common. The incidence will vary, but up to, people up to 50, 60%. The time of recurrence, very important here, is they can be very long. So you really have to follow your patients. We've seen patients 18 years out that subsequently have had a recurrence. The peak time recurrence, 1 to 5 years. These are difficult management problems, no question, with increased treatment morbidity, decreased favorable treatment outcome. And if you interestingly look in the literature, there's no real consensus on the optimal management of these residual recurrent. When do you do repeat surgery? When do you do the radiation? After the first recurrence, after the second recurrence? There's nothing in the literature that helps you with this. But we do know that the management often of these require a multidisciplinary approach. This is the recurrent rates following microsurgical treatment of pituitary adenomas from the 1960s on. With the microsurgical, you can see non-functioning growth hormone adenomas. Our endocrinologists who follow these for many years tell me at least up to 80% of patients with acromegaly ultimately fail and out of remission. So the risk factors for recurrences of pituitary adenomas, of course, incomplete tumor resection at the initial surgery. There's some issue with regard to tumor biology. Of course, infiltration of adjacent structures, particularly the cavernous sinus, is a major issue. Size, age, sex in some series, these are shown to be valid. In other series, they're not. Of course, the importance is the experience of the surgeon. We know that from way back. And as I mentioned, duration of follow-up. So a 2-year follow-up in a pituitary series means nothing. The treatment options, of course, are like they are for primary lesions, except we know that repeat surgery carries a higher risk for morbidity and a reduced chance of total removal. We've done over about 2,000 cases now of endoscopic pituitary adenomas in our department here. And the question was, with regard to recurrences, has the endoscopic techniques improved our ability to deal with recurrent pituitary adenomas? So we looked at, if you look at this patient here, 51-year-old female, persistent Cushing's after previous microsurgical procedure. You can see, and I'll just, again, not bore you with that. The issue was that the lesion was posteriorly back with a partially the type 2 conchal sella, and we drilled down part of the upper clivus that allowed us to get to this nice, beautiful little Jules Hardy type of microadenoma that you can see here. We're able to get a very nice removal. Here's the medial wall of cavernous sinus that we can take it out very nicely from the medial wall of cavernous sinus. Here we are after the removal of the tumor. This patient subsequently, as you see, had normal urinary free cortisol, 7 years, remains in remission. We never say we can cure or at least cure a Cushing. We say we put them in remission because they will likely recur. Now, this is a 67-year-old patient with persistent acromegaly. You can see this virtually a conchal sphenoid, very difficult. And this patient had a microsurgical approach, remained not in remission. And this is the endoscopic approach that allows us to do this. We obviously drill down the upper clivus that allowed us to finally find the cellar floor that you can see here. And then ultimately we can get a nice removal. This is the medial wall of cavernous sinus. And just to show you here again, and this patient is post-op 5 years again in remission, not a cure. We do not say cure. There's a 53-year-old patient, 2017, microscopic partial resection. The problem was this. Look at this, kissing carotids. And how do you deal? Well, they obviously were able to get a partial but significant residual. So the endoscopic allows us to get, I think, a better resection by going above basically the carotid vessels. And here very quickly to show you what we did, you get a nice exposure that they did not do initially. So the carotids are here, basically here and here. So we go above the carotid, do it even a partial expanded to allow us to get over. In this patient, as you can see here, we got a removal, not a total removal, but you can see this resection. We improved the patient's vision, which came back virtually to normal. So this is our series that we published back in 2012 because we wanted to look at the endoscopic surgery recurrent pituitary adenomas, 39 patients. You can see here the demographics, 19 non-functioning, 20 functioning. And unfortunately, as you can see here, 43% of them already had frank cavernous sinus invasion. What we looked at that time, we wanted to know what is it, why could it be better? And the results from an anatomical point of view, we found that 3/4 of the cases, the sphenoidotomy was not wide enough, lateral and rostrocaudal, and in 2/3, the cellar opening was limited, and this restricted the working area and angle of view. The results. The results, yeah, we had a little problem. The gross total rates was 54% in the entire series. The gross total removal rates in non-function was 86% without cavernous sinus invasion, 0% in those with cavernous sinus invasion. I personally do not believe anyone can get a total removal of an adenoma once it's purely infiltrated the cavernous sinus. And some people disagree with that, but that's my view. In functioning adenoma, Cushing 75%, again in full remission, however, not when there was evidence of cavernous sinus invasion growth hormone. We looked at these and compared them to the microscopic theory, and overall, these were better results than in most reported series of recurrent microscopic surgery. Cavernous sinus invasion was the major predictor of outcome. This is a more recent series that we just published, that at least just been accepted now by World Neurosurgery. It should be out very soon in October. We wanted to look at now long-term outcome, because as I've told you before, the importance of following these patients long-term. We wanted long-term outcome, and how did we manage these recurrent tumors? So this is a series, 269 patients with non-functioning. Here we did not have functioning in our series. We wanted to look at non-functioning, the tumor characteristics, the pathologies that you can see here. So these are the results. The overall recurrence rate was 20.5%, 22% at 5 years, and 47, almost 50% at 10 years. The median time to recurrence was 10 years for patients without cavernous sinus involvement and 6 years for those with cavernous sinus involvement. Among the recurrences, 82 had only a subtotal resection, 18% had a gross total resection and had presented with a recurrence. Among the recurrent cases, 63%, 2/3 had evidence of cavernous sinus involvement prior to surgery. Now, it's interesting that 1/3 of these were symptomatic with visual worsening, but 2/3 were asymptomatic. Looking at the risk factors, under univariate analysis, size, of course, cavernous sinus invasion, anterior skull extension, residual tumor after surgery were significantly associated with recurrence. Under multivariate, age, tumor size, cavernous sinus involvement, and residual tumor were associated with recurrence. Silent corticotroph, in terms of type, had seemed to have a higher tendency, and we're all aware of the silent corticotroph subtypes, but they were interesting, were not statistically significant. So how do we manage these recurrences? 52% of patients required a second surgery because of visual symptoms or to prevent visual complication from growing lesions. The gross total removal rates that you can see here, only 28%, only less than 30%. 15 patients underwent radiation. You can see 9 gamma knife, 2 fractionated, 10 after the first recurrence, and 5 after the second. Tumor control rates with radiation was 87%, the mean follow-up of about 37 months. So back to our other patient that I began at the beginning. So this is patient 2, microsurgical approaches, 2 endoscopic approaches. Now, a recurrence in the cavernous sinus, what do you do? Well, there's no question to me, surgery is not the answer for this patient. So this patient, we recommended radiation, and this patient, as you can see here, is now 5 years with stable disease. So radiation is no question, it doesn't matter people who don't like radiation, but radiation has a significant role to play in recurrent pituitary adenomas. Various types of radiation have been used. If you look at the literature, you can see in terms of functioning and non-functioning, up to 50, 60% remission rates. But non-functioning, as you can see, are up to 88% at 5 years control. This is one by Loeffler, looking at a literature review with evidence synthesis, a very high success in controlling tumor rates up to 90%, regardless of the radiation technique used or adenoma subtypes. There is, of course, the issue of hypopituitarism, which is an expected result of radiation therapy, but overall rates of other treatment-related adverse effects were quite low. Now, the management of recurrent adenomas, also there is medical management. I don't have time to go through these today. We work very closely with our endocrinologist, and no question that in these recurrences, sometimes medical therapy is really very effective, and these are used in our patients with recurrences, particularly the functioning adenomas. So in conclusion, despite advances in surgical technique, recurrences after rates of non-functioning adenomas after surgery remains high, especially noted if you follow these patients long enough. We looked at the risk factors. I won't go through this again. However, there's no question that an attempt should be made for a safe maximal gross total removal when feasible at the first surgery. While the success of second surgery, as you see, is significantly less, in terms of gross total removal, there's no question that reoperation still has a significant role to play in achieving reduction in tumor bulk and decompressing the visual pathways in symptomatic patients. While the time of radiation remains a subject of debate, you do it right after the first recurrence when you've got something in the cavernous sinus. There's no question in my mind that it is has a significant role to play in recurrent tumors when gross total removal is unlikely to be achieved after multiple operations and in tumors showing an aggressive behavior. So the management of giant pituitary adenomas. The incidence is in most cases, as you see here, from 5 to 14%. These tumors have increased incidence of neurological endocrine dysfunction. They have capacity for very aggressive local growth and involvement of adjacent structures. They are surgically challenging. Their curative rates in these, or at least gross hormonal rates, are rarely above 50%, often less than that. They have increased morbidity and mortality, increased recurrence rates, and overall poor treatment outcomes. And again, the optimal management, if you go in the literature, you don't really get a clear of how to deal with these tumors. The treatment options are the same as they are for recurrent tumors. This is just to show you a 58-year-old patient with visual decline, as you can see here, with this giant adenoma that will show you. And again, very, very quickly, here's the tumor, a large tumor going up almost to the foramen and above. And just to show you, I'm not going to bore you with this. We always do middle turbinectomies in our pituitaries, and particularly in these. We always do a nasal septal flap, and particularly in these patients where the CSF leak rates may be more problematic. Then, of course, in these, a wide sphenoidotomy is the key to these. And then this allows you a very nice exposure that you can see here, and then basically the usual techniques of dural incision, and then the multi-layered removal that we do. And this is a diaphragma that has nicely descended. We go laterally to make sure we've removed everything from the medial wall of the cavernous sinuses to ultimately get a very nice removal of this tumor. And of course, here's our nice nasal septal flap that we use for the repair. And this patient, as you can see here, day 1 post-op, nice removal. And this is now 2 years out, again, looking like stable disease. Significant improvement is in his visual acuity, but as you can see, visual fields often do not improve as well, particularly if they've been long-standing. This is a it keeps going back. This is a 74-year-old patient with this large tumor. Again, very quickly to go through, there we are. And sometimes you can even try to achieve a extracapsular removal, as you can see in this patient. Ultimately, we got a nice removal. There's a diaphragma coming down. And this patient, just to show you post-op, has bleeding. Now, some people are concerned about this. As long as the vision is not a concern, do not worry about these, because you've got a large space and something has to take its place. So you often see this bleeding. Not to worry if the vision is stable. We do not, obviously, we don't go back. And you can see here at 6 months, it's come down very nicely. So this is often you see this with giant adenomas postoperatively. Now, what about this patient? This is a patient with a large tumor into the sphenoid, sella, and anteriorly. Maybe in the past, we would consider doing this an open approach. With our extended approaches now endoscopically, this is one of our first extended endoscopic approaches. And here we go to just show you. This is, we remove the tumor from the sphenoid down here. Now we're going to remove the tumor from the sella, showing it here. But after we remove that tumor, we don't get this component coming down. So this is where we do the transplantar, tuberculum approach. And then we'd be treated basically like a meningioma that maybe Luigi will talk about. And we come above the tumor, and then as we take it down, you can see a beautiful view of the chiasm that we taken it off. And here's this patient post-operative scan. And you can see here, I think he's now 8 years out. What about this patient? Very ugly looking tumor, MN1. With elevated prolactin, but this is obviously not a prolactinoma alone. It must be a mixed, because prolactin should be in the thousands for this large tumor. This patient obviously did not respond with just dopamine agonist. We did an expanded endoscopic approach, but look at the residual that was left. What do we do now? Well, the issue is, do you observe it? Do you go repeat surgery from above, radiation, medical therapy? Well, our feeling was that this patient had significant residual. We're not going to watch it, and we recommended radiation. He had fractionated stereotactic radiation, 50 gray, 3 years with stable disease. What about this patient? Long-standing visual, virtually blind. You can see finger counting. What is the best approach for this? This patient we did with an endoscopic approach. As you can see here, this is a residual, significant residual. Look at ischemic changes in the thalamus, likely perforator injury. This patient did very well, very poorly, very bad outcome. Left hemiparesis, cognitive dysfunction, worsening of vision to bilateral finger counting. So was this the right approach? It's difficult to know. And so this is the problem with giant adenomas. You can get poor results in some patients. The limitation of the transfemoral endoscopic approach: large invasive adenomas, lateral extension, multiple compartments, and vascular encasement. So this patient, as you can see, back in 2003, this is just when we're starting. What was the best approach? Well, I felt that endoscopic approach, we're just starting, was not a good approach for this. So this one I did basically open. I used my classical approach for the open is an interhemispheric transbasal approach. And you can see this very nicely here. Here's the anterior communicator, the prechiasmatic, and this appears. So what we do is go through the lamina terminalis, a prechiasmatic space, allowed us to get a very nice debulking of this tumor. We don't kill ourselves, or you get a total remove, but here's this patient here very nicely. And now this patient is 15 years and he's remained stable. We never understand why this patient remains stable and another patient, will recur. So this is our series that we presented back in 2014 now in our group in Toronto. You can see here the definition of giant and large varies in the literature. What we used was a volume-based definition we thought might be more sensitive. And 10 cc's was our definition for giant. Here's the parameters, the clinical demographics. The outcome, what we really wanted to know was what was the extent of resection that we could do. And then, of course, the endocrine changes and the complication rates. So 73 patients, just like as I said in the series, it was 12% of our overall series of almost 600 patients. Here's the demographics. And 16% had prior surgery already, 4% had prior radiation. The presentations were generally optic nerve issues that you can see here. And the average size was quite large. You see almost 18, 19 cc's.
Fred, 3 minutes if you could. 3 minutes.
Good. Thank you. This is the characteristics. I won't go into that. They are pure endoscopic. 5% we use in expanded approaches. What are the results? 24% where we felt we got a gross total removal rate, which you might say is pretty low, but that's the reality, I think, and it's an honest issue. Now, the issue is the predictors of resection. Maximum tumor diameter is obvious, tumor size, also hemorrhagics. These are always fibrous tumors that were made it more difficult. Of course, invasion, particularly in the cavernous sinus. The non-significant, which was a bit of a surprise to us, was that prior surgery did not seem to be a significant parameter, or prior radiation, including biological tumor characteristics. I thought, MIB, etc. And this is on the complication. CSF leak was 10%. And I'm not going to show you the literature in terms of giant adenoma. This is from the Schwartz group showing they looked at endoscopic versus open, showing a significantly better outcome after endoscopic. This is our own series, at least guidelines that we looked at, systemic review, 33%, very similar to our series. So in conclusion, Jacques, the endoscopic approach can obtain an extended resection equal or higher than transcranial techniques. Endoscopic approaches are safe and more effective in alleviating symptoms in these giant adenomas. Transcranial approaches are still necessary. In our series, about 3%, 2 to 3% still require craniotomy. And no question that radiation therapy has a definite role to play in controlling residual disease. And then just basically that the evaluation and management of patients with recurrent and giant pituitary adenomas requires, I believe, an active participation of an experienced pituitary surgeon, as well as equally experienced multidisciplinary team of endocrinologists, radiation oncologists, medical oncologists, and pituitary neuropathologists. So it's really a team approach, and thank you very much for your attention.
Fantastic, Fred. Thank you. Vast experience, many pearls, many lessons to learn for everybody, and this was masterful. Thank you so much. If you could, you stop sharing. Great. Luigi, your turn. And again, I cannot thank you enough for your willingness to do this late in the evening in Napoli. But we're ready to hear you now. And we will forgive you if your voice crackles as you speak. We know it's late.
Thank you so much. It's as usual, it's a true privilege to stay with you. And in the next minutes, I'll share with you the experience of our group from Naples, as you say, guided by Paolo Cappabianco, who is my mentor, my master. And the topics, as you say, concern the endoscopic management of anterior skull base meningioma. This is on a cadaver, the perspective of the midline skull base that you can expose when you pass through the endonasal route. And these are the kind of meningioma that you can approach through the endonasal route. And we will focus our attention mainly on tuberculum cell meningioma, on planum and olfactory groove, but as you can imagine, the rule for petroclival and also on cavernous sinus is quite limited for the endonasal route. This is our series, and through the nose we manage 79 meningiomas, and the vast majority is represented by tuberculum cell meningioma. And this is a transcranial perspective, as you can see here in this slide, of the amount of bone you have to resect when you deal with the tuberculum cell meningioma. You create a sort of craniectomy just in front of the pituitary gland and the chiasm and optic nerve. And through this hole, you can approach and remove some selected tuberculum cell meningioma. And it's very important to underline one point. When you deal with the tuberculum cell meningioma, the opening you have to do over the skull base surface is much larger as the one you do for craniopharyngioma. You see here you have to expose on both sides the supraclanoid portion of carotid artery. You have to see the optic nerve entrance into the canalicular part of the canal. And this is very important, otherwise you will miss some part of the tumor in this corner, and you will lose the benefit you can have when you approach this tumor from below. So this is very important to underline. Of course, the factors affecting the outcome in tuberculum meningioma surgery are the same you have to consider when you approach this tumor from above. And the first one, of course, concerns the tumor dimension. And as you can imagine, usually the size of the tumor we approach from below is smaller as compared to the one you approach from above. But of course, we have removed not only small tumor, but also some tumor of medium size like this one, or even this larger one. And you see, for example, a case like this one has been operated with a transcranial approach elsewhere, and this is the post-op result. You see just a little bit more than a biopsy with some brain damage. And this patient we have then operated from below, and you see that at the end we were able to remove, and this is the only sign of the previous surgery. Another point to consider, of course, is the optic canal invasion. And regardless to the size, sometimes you can have a large extension of the tumor inside the canalicular part of the optic canal, with only a small part of the tumor growing over the tuberculum. And this is important to know that if, for example, for a craniopharyngioma, you can open just the tuberculum and the limited part of the planum sphenoidalis, with the endoscope you can when you have to deal with tuberculum meningioma, you can extend much laterally your bone removal, even on the lesser sphenoid wing, even on the roof of the orbit, and sometimes this is necessary. What you do practically is to drill over the supraoptic recess. You have to drill over the lesser sphenoid wing. This because allow you to gain space over the optic prominence of the optic nerve, and in this way you are able to control the entire course of the optic nerve up to the annulus of Zinn. So you can open also the canalicular part of the nerve, and you can have a wider view not only on the inferior surface of the optic nerve, but even above. This is one case of a quite small tuberculum meningioma, but with a wide extension inside the canalicular part of the optic nerve. You see here the ophthalmic artery, but look what happened when you have to deal with this tumor. You have a broad invasion of the dura, not only at the level of the tuberculum, but even along the canalicular part of the optic canal. And even if you are able to open this this canal, for sure you will never be able to remove completely the dura around 360 degrees around the optic nerve. This because, of course, the endoscope is not a magic wand, and probably the answer for this kind of tumor infiltrating so much the canalicular part of the optic nerve is not the knife of the endoscope, but maybe in this case we have to find other kind of answer. But of course, the main benefit of the endoscope when we deal with this kind of tumor is the fact that we dissect the tumor from the neurovascular structure which are almost not touched, like in this case, which of course had a good arachnoid plane, but it's just to give you an example of the strategy we use. We manipulate the tumor and we almost don't touch the optic nerve or the vessel. And this is very important, maybe not for this minor compression or moderate compression, but it's very important case like this one, when you have a severe damage of the optic nerve with a very bad neurovascular conflict like this one. In case like, for example, the patient has just light perception or a very bad visual field defect, with this approach you can preserve the residual visual function. The extent of removal, of course, it's comparable to the transcranial series. The visual outcome are quite good, and even if we look in the literatures in different series reported by different authors, usually the rate of improvement of the visual function in the endoscopic series is almost every time quite good. And we have tried to compare also our result with the larger transcranial series, but of course it's not so easy to compare endonasal series with the transcranial series. And it's quite obvious because the more complex, the more larger tumor are of course approached transcranially. But at the end, the idea that, and not only the idea, but what comes from the results is that the outcome on visual function is generally quite good. And this is the same what came out from a European sort of consensus we made recently through ENS. Of course, not all the tuberculum cell meningioma can be approached from below. You have, of course, to consider some factor, like, for example, the size and the extension, especially the paramedian extension of the tumor, the vessel encasement, and of course other factors. But when you consider vessel encasement, you have to know that we have dealt even with some limited encasement of vessels. But of course, sometimes I'm not sure that even transcranially you can choose to remove completely tumor in which there are encasement, like in this case, for example. But of course, when there is a complete vessel encasement, you have two proper selected cases, and there are of course cases which no way to say that the right route is the transcranial one. Another point to consider, of course, is the sphenoid sinus configuration, because there are configuration, for example, like this one, when you have a flat tuberculum cell like this, in which the endonasal route is favorable, but there are cases in which you have a configuration, small sphenoid sinus, and this configuration of the tuberculum, in which the endonasal route is of course more difficult. And you see, when you have a flat tuberculum, you have the chance to work not only below the level of the chiasm, but also you can have a wide view also above the chiasm. Then we can move more anteriorly to the planum for to treat just pure planum meningioma, like this one. Of course, you can remove this tumor from below, but no way to say that when you have a broad attachment of the meningioma over the entire surface of the planum, this case, of course, has to be approached from above. Same principle we apply also for olfactory groove meningioma. In this case, honestly, the approach is even more easy, because we don't have main neurovascular structure which are surrounding our skull base hole, because we are working in between the two orbits, the posterior wall of the frontal sinus and the planum sphenoidale posteriorly. And of course, the main benefit is like for tuberculum meningioma, you open the dura, you can easily start to debulk this tumor like convexity meningioma. And especially if you have a good arachnoid plane, this is also quite a fast procedure. You can easily debulk and dissect the tumor from the brain. And the picture you have at the end is, of course, of a normal brain, almost not touched. The limits are usually the half of the orbit, and you need a cortical cuff just behind the posterior wall of the frontal sinus. You can remove even quite large meningioma like this one. But the problem, of course, especially in the past, was the reconstruction of this large skull base defect. And the benefit in this tumor, especially when are so large, is the fact that even with this severe brain edema, you almost not touch don't touch the brain when you remove this tumor. Of course, we do not operate all the olfactory groove meningioma through the nose, because, for example, there are some olfactory groove meningioma in which the patient is not anosmic, and if you go transcranially, you can preserve the olfaction. So the first condition to operate this tumor from below is the fact that the patient has to be anosmic. And another point is that it's better if this tumor have some extension inside the nasal cavity. This because going through the nose, you can do a skull-base approach, removing in one section completely the endonasal part of the tumor, together with the skull-base part of the tumor and the intradural part of the tumor. And these almost without touching the brain. So these are the two main conditions we consider when we approach this tumor from below. Last but not least, I would spend some minutes on the reconstruction, because this was considered a sort of Achilles heel of this approach. And over the year, we have really tried all the technique and materials available over the market. And after 20 years, the result of all our attempts are synthesized in this technique, F3, which is made just of fat, flap, and fast mobilization of the patient. So it's quite easy, seems to be quite obvious, but to reach this kind of reconstruction, it took for us a lot of years. So basically what we do, we simply use the fat like a cork stopper. Of course, fat has been used in transsphenoidal surgery since the 70s, but it's important to underline the way we use the fat, because we don't use the fat intradurally, we don't use the fat into the sphenoid sinus, we simply use the fat across the entire skull base defect. It's really like a cork stopper, like you see here in this picture. And this for us was the best way to seal all the corner of the skull base defect. So we don't use anymore any multi-layer reconstruction. We don't use gasket seal, no ballooning, no lumbar drainage. We simply don't close anymore the cella. This was for us the big advance. We don't close the cella. We just use one material across the skull base defect. Of course, we cover the fat with the flap, which is another big advance in skull base reconstruction, because a fast healing of the skull base surface. So fat and flap, and we have completely abandoned all the other kind of synthetic resorbable material we have used in the past. And last but not least, also this one was another factor we changed completely over the year, the flash mobilization of the patient, because in the past we were using to take the patient in the bed for 3-4 days, at the beginning in the supine position, and that was for us a mistake, because we tried to mobilize this patient as fast as possible. And I would like to conclude with just one case of reconstruction in a tuberculum cell meningioma. You see quite a large osteodural opening with a regular shape, and we just simply plug a piece of fat across the skull base defect. There's no risk of overpacking with the fat pushed inside this way, because the excess of fat will be pushed outside by the intracranial pressure. You can simply try to tilt the table above and below, and you will see how the pressure of the fat over the skull base defect changes. So in all the cases in which we have used the fat in this way, we never had any case of overpacking. So we just fix the fat with a thin layer of fibrin glue, and then we cover, as usually, the fat with the nasoseptal flap. And then we fix the flap with the sans surgical to fill completely the sphenoid sinus. That's the post-op CT scan. You see how the fat is positioned. It's not inside, not outside. It's just a cross completely from inside to the outside skull base defect. And you see the way how the fat goes around the skull base defect. How to check this patient? We usually use a suppression fat sequences at 3 months post-op to check eventual remnants of the tumor. And another point you have to consider that over the time, the fat will be resorbed. And we now are going to consider what happens when you have to redo surgery. And we have one experience with the craniopharyngioma to reoperate a patient with this kind of technique after craniopharyngioma surgery. And of course, it's just one case, but the impression is that we have not so much scar and no more scar as we had in the past with other technique. And I think this is the last slide, and thank you for your attention.
Thank you, Luigi. Very nice, and you're certainly even within your time limit. That was excellent, and thank you for reporting the Napoli experience. Actually, I'm gonna take the liberty to ask you, Luigi, one of the audience questions. Dr. William Martinez from Lima, Peru is asking, with the COVID pandemic, what is going on with transsphenoidal surgery? Can you tell us a little bit, maybe the history of what your institution has done and what you're doing now?
There was a lot of people scared about this approach, especially at the beginning of COVID. We had a lot of restriction because, of course, that's the way the virus entered. And we, in the first stage, stopped completely the endonasal procedure. Then we gradually start again to do with all the maneuvers and testing available. But actually, that is the situation.
Okay. All right. So before I pass it on to Corina Levin, I'm gonna just share one case to get the opinion of the panel, to get us going with the discussion, because this is a recent case and I thought might be useful to get the opinion of everybody here. So this is a 54-year-old female with bitemporal hemianopsia with this, well, presumed pituitary adenoma. Luigi, let me start with you. What would you do? Endonasal, transcranial, non-functioning.
Non-functioning pituitary adenoma. So yes, it's not an easy case, but I would propose extended endonasal.
When you say extended, you mean transtubercular, transplanum, or is that
yes? Yes, what we do usually is that we start doing a standard opening of the sella, and if the tumor is soft, because we are lucky that day and we saw on T2 sequences that the tumor is soft, maybe you can have the chance to remove through a cellar corridor. But this seems to be a double-shaped tumor, so maybe just a cellar approach would be not enough. So we have to be ready to open also the planum and to work also above the diaphragm.
Okay. Fred, what would you do? You're muted, Fred, you're muted. And please, panelists, open your microphones. This is now, we're gonna all talk to each other, so.
So I think, I would agree with Luigi. This is someone you say you can try a transcranial, but to me, this would be a case for an endoscopic. And then the key is to open up a little bit of tuberculum and planum, because that allows the things to come down. The problem is if you don't, it's like you have a narrowing there and the things do not come down. So it's nice to give that opening that allows to go down, to come down. So definitely endoscopic approach.
Mike Chicoine, transcranial or endonasal?
I would agree. I would do this endoscopic, endonasal, tubercular, transplanum if need be. As Fred mentioned earlier, sometimes these things don't deliver down. So you'd be prepared to look deep in there. We have the advantage, we use an intraoperative MRI in these cases, and we can see what we might have left behind. It sometimes helps us identify something that's higher up there, but sometimes treacherous. So can't always be certain it's all going to come out, but that would be my first attempt.
Phil, do you agree?
Yeah, I would agree in principle. You know, in practice, I can tell you that I haven't done an open pituitary in probably 2 decades now, and we've done more than 1,000 of this endoscopically. But I do not tell everybody that. I don't consent everybody for an expanded endoscopic, and I do not discuss risks of an expanded endoscopic with everyone. So, although I see what Luigi says, I would take what I can, and if not, if I can't deliver the top with a lumbar drain or with anything else, I would just let it be and see what happens in 2 or 3 months. And I would either go back and do an expanded approach, and or if it's not that much or it comes down, maybe do it again just purely endoscopically.
Luigi, what features do you look for in an MRI to tell you, oh, this is not good for endonasal and we should do transcranial? Or do you always do endonasal? Would you rather achieve an intentional partial resection endonasally sometime? What's your philosophy with the giant ones?
With the giant one, of course, when there is a vessel encasement at the level of anterior perforation area, perforating vessel, when you see on T2 or flare some invasion around that area, I think that even transcranial approach, you can have problems. So the problem with giant is that sometimes you have to remove as much as possible, because if you left too much tumor, you have infection. So you have always to balance what is the best, to remove as much as possible or to leave some remnant and risk to have a bleeding of the residual tumor. So sometimes maybe, as Dr. Lowe said, the better is not to operate at all this patient, especially when they have just few symptoms from some giant tumor.
One of the audience members is asking who would use an ultrasonic aspirator in this type of tumor.
No, I would not.
Luigi, do you use technical, ultrasonic aspirator-like instruments?
For pituitary adenoma, very rarely we use ultrasonic aspirator, but for this tumor which grows so deeply, we need a special instrument. For example, the standard suction cannula, for example, are not long enough or curved enough. Especially if you work with endoscopy, you need at least 15 centimeter curved suction cannula, because this is what happened to us the first time we tried to go so deep. We had not long and especially curved enough cannula to reach the deepest part of the tumor. So
a little bit, it reminds me a little bit of the initial problems we all had doing C1, C2 resection endonasally,
yeah, exactly.
We need to use the 17 centimeter drills to get there. Yeah. Okay. So this patient was at another institution, and the neurosurgeon there decided to do a left craniotomy. According to him, when he called me later, said encountered fibrous, fairly bloody tumor. He achieved partial resection. Frozen section is a pituitary adenoma, but the patient woke up blind in the left eye on the side of the craniotomy. Here is an immediate post-craniotomy CT scan. Dr. Chacoin, so the neurosurgeon calls me and tells me the story, shows me the post-op CT. What do we do now?
Very concerning. Doesn't look like a whole lot has been removed, best I can tell from the scan.
That's right.
I think still my intention would be to go endonasal endoscopic to try to decompress this as much as possible. But once they start losing vision like that, it could be a treacherous situation. May or may not get it back, but hopefully could potentially recover some vision.
Would you treat this as an emergency?
I think I would.
Would you sit on it to let the dust settle? What would you do?
No, I would probably do this as promptly as possible. I'm concerned. I don't know, you have to look at all the images and see if there's any obvious hemorrhage into this and so forth, but, and hard to know what happened. I mean, was there any evidence of arterial injury?
No, he said he just had difficulty because it was fibrous and moderately bloody. It wasn't a bloodbath, but some of these adenomas can be a little bloodier than others. He saw the optic nerve and then realized he cannot remove the whole thing, so he quit.
Yeah, I guess the other consideration would be, to go back through the craniotomy and do an optic canal decompression, clinoidectomy, and see what you could accomplish that way. But tough case.
Okay. Yeah, I would do in a redo case like this. I would not go endoscopically. I would do it transcranially again, like Mike was just saying. I would just go transcranially and try to decompress and take as much as possible and obtain hemostasis. I think it would be a mess to go from below.
Why do you say that, Phil? Because of the...
If it's hemorrhagic, I can't tell if there's blood here or not, but if there's an acute change in the vision.
No, but well, it's not acute. She woke up like that. I mean, immediately post-op, she woke up blind in the left eye. There was no hematoma yet.
Yeah. I mean, I would probably still go transcranially, but...
Okay. Fred?
So, I think she's blind because he went in the left. He manipulated the optic nerve, and as you have to do with these, you have to work over it, and that's why she's blind. It's probably a mechanical injury. So, no, I don't think going back in craniotomy-wise is going to be any benefit unless, in terms of I would go transsphenoidally with this. I don't think I'd rush in. There's no, I want to see sometimes that vision can improve. This was immediately after. I don't know if she's remained blind, but I would, not rush back in, but ultimately go back endoscopically.
Luigi?
Yes, I agree with Fred. I will go endonasal. I agree, endonasal.
Carolina, Carolina, how would this have been handled in NYU, where you were more than a year ago, even though now you're in Miami? But
I think in that situation, if he's saying that he went in and he had trouble, my guess is likely a mechanical injury too, especially if you don't see a hematoma that really is compressive, causing that blindness. So I think we would actually have gone endoscopically as well. And not necessarily acutely either. Was she in the hospital still when he called you? Like, was he?
Oh, yeah. I mean, he was rounding on. I mean, it happened that day. He called me that evening. I said, okay, arrange for an emergency transfer to me. Mm-hmm. Anyway, so not to belabor the point, sorry. So I treated this as an emergency. I took her for an emergency. I mean, like the minute she hit our hospital, this was like 7 or 10 days ago, I did endonasal, endoscopic, transtubercular approach, as a couple of you, I don't have the video to show you, but this is how it was pre my surgery. And then we removed it completely, of course, with the help of my trusted rhinologist. This is post-op. It was able to bring it down, even though there was this hourglass appearance, and that's also pre and post-op. But the gratifying thing is she immediately improved her vision. She at first, like waking up from this endonasal, she was not counting finger. She was seeing light. By the time we discharged her 2 days later, she was counting finger at the 3 or 4 feet. So I certainly do not regret treating it as an emergency. What I found at surgery, I mean, the optic nerve was fine, was not injured mechanically. There's a small amount of surgical blood, but it wasn't a hematoma problem. Just the swelling of the tumor, I think, compressed the left optic nerve. Just to show us I think it's a good example of the benefit of doing it from below. Of course, I don't know if I would have achieved the same good result going transcranially again. But
you manage the fibrous character of it from coming from below?
Wasn't, you know, I wouldn't have called it very fibrous. I'd say it's medium fiber. I mean, it wasn't like this, you know, well done steak that you can barely move. It certainly wasn't suckable. So I had to remove it piecemeal and tug down and get around it, but wasn't the most horrific texture I have seen.
So the audience is asking, are there any MI correlation with consistency of the tumors in order to be best prepared from the approach standpoint? What do you guys?
Okay, any of you would like to answer that question? Can we tell, does MR elastography, do you guys use MR elastography? Do you have other tricks to predict texture of tumors? Any of you?
We've tried, and the literature has tried, you know, many, and in the end, I don't know if there's a very good predictable issue, and that would not, for me, make a decision on whether I would go transcranially or not. So it doesn't make any difference, you know, to me in terms of approach. But predictability, 100%, no, you can't be sure.
Yeah. But maybe in the future we will be able to rely on radiomics. You know, radiomics is a promising technique, and maybe will give us more information, because up to now we rely mainly on T2 sequences, which sometimes is useful, of course not in all cases, but maybe radiomics in the future will give more answer.
Okay,
let me have experience in other field, but radiomics seems to be, with this machine learning, maybe. What do you think?
I don't know. I hope so. Yeah, I mean, I don't know that it would really change the approach you would choose. I'm not sure. I don't think so in most cases. Okay, let me invite Corina Levin to share her screen and show you guys whatever she would like to show you.
So you asked me to bring a case. So I have a case. This is kind of a strange case. So I have an unknown skull-based tumor. This is a patient who is a 49-year-old male who came with a nasal mass. He had red-pink discharge on the right for a little while prior to arriving. And then just before he had come to see me, he had this severe epistaxis episode and had gone to an outside ENT who tried to scope him. He had very bad crusting in that area and scabbing from his previous bleed, and that blocked the view. And so on my physical exam, we saw that all the cranial nerves were intact. This patient's vision was intact. He had no lymphadenopathy, really no deficits other than saying the right side of his nose felt kind of blocked now since he had the nosebleed and he'd been having this drainage. He did get imaging performed, and it showed a sinonasal mass that was eroding through the skull base. And so I'll show you guys a little bit of that imaging. So here are a couple slices, one from the CT scan where you can obviously see the erosion of the skull base, and also one of the axial cuts on the MR, just so you can see the extent of this tumor. And I'll go through just a very brief video of what we had on our MRI, but you can just see in this coronal plane the extent of this tumor that extends up really basically from lamina to lamina up into the skull base, and then has some post-obstructive component in both the sphenoid and the maxillary. And I've shown you some still visuals here as well. So based off of this imaging, does anybody have an idea of what they think this is, just on the imaging alone?
So I think the differential here is, usual. He's 54 years of age. This is either going to be an esthesio or an adenocarcinoma. I think those would be the top. I think squame is probably not that possible. So I would put esthesio and an adeno high on the list. I mean, but differential is very, very, very large going down.
Mm-hmm. Anyone else have anything different to add?
I mean, a snack maybe like this. So it's not biopsied yet, right? They tried.
Not been biopsied yet. So that is the next thing that we want to think about. Here we go. So In endoscopy in clinic, this is a red-purple mass. It's filling the right ethmoid. It's pushing the septum to the other side. And it didn't look highly vascular. And I had some imaging. So I knew it wasn't brain hanging down, and it certainly didn't look like that. So I biopsied it in clinic. And this is what we got for pathology. I did give you guys all the details. A typical epithelial and spindle cell neoplasm, positive for SMA and negative for just about everything else. And it was a good biopsy. In fact, the pathologist commented on it. We had quite a large piece, and they still could not figure out what it was. And they had 2 very good head and neck pathologists take a look at it. So based off of this, does anybody have any guesses on what it might be or want to revise their thought process?
So it's very interesting, Karina, you say this, because I had a patient very similar to this. This was involving the lateral skull base, intertemporal, where it was the final diagnosis, and this was sent, not only our head and neck pathologist, sent to Boston, sent everything, the end of a spindle cell neoplasm. That's the, despite all of the immunohistochemistry and so forth, I reoperated on the patient to try to get more molecular profiling to see if we could get a type of a targeted therapy. So sometimes, yeah, you'll find nothing more than a spindle cell, neoplasm. Yeah. I mean, it's not a schwannoma, obviously, in terms of spindle cells. What are spindle cells? They're not really a schwannoma. Could it be a hemangiopericytoma? But you said it wasn't that vascular, so that's unlikely that. Very, very interesting.
It was very strange. So they asked me, I talked to them, and they said, we need more tissue.
Yes.
I apologize because they rarely would ask for more tissue given the level of biopsy I gave them, but they asked for more tissue. So we got them more tissue. I took the patient to the OR, and we intraop sent it down for frozen. They said, well, it's a malignancy, but we just can't tell you what. And so then we went and reviewed this at our head and neck tumor board, where they have the pathologist do kind of a second look on finalized pathology. So it got, now a 4th review. It's positive for P63, keratin, A1 and 3, and CK8 and 18. Anybody have an idea what it is now?
I don't know what to make of all that alphabet soup of immunohistochemistry, but malignant peripheral nerve sheath tumor, could it be that?
No, it was negative for BRAF, and it was craniopharyngioma. And the reason that we really discovered there was craniopharyngioma actually happened to be the pathology fellow who had just done a different rotation and said, oh, you know what, this really looks like craniopharyngioma. And then they went back and they had all of the neuro path people look at it. And then they went back to my original biopsy and they concluded that it was craniopharyngioma. So we finally had a diagnosis for this patient. And then, it's really planning as far as what we would do. So if
where from though? So originating from what?
Yeah, so it's very interesting. So it doesn't connect in any way with the pituitary.
Do you have, Corina, you have a sagittal MRI or no to show us?
I don't think I have the sagittal on this. I have an axial, but not the sagittal.
So
there will be one on the video. And you will
Corina, it's very, again, amazing. I had a patient like this about 6 months ago. This is an ectopic, if you say, craniopharyngioma arising. This one arose from another type of tumor. So it was, in the sphenoid sinus. And of course, the craniopharyngioma originated from Rathke's pouch, which go from the mouth all the way up. So then this is, it can happen, and they are malignancy. They're a malignant tumor, which was a malignant craniopharyngioma arising from another type of tumor in the sphenoid.
That's very, it was very strange. So we ended up talking about this patient at a tumor board and then proceeding to do our resection. So I'm going to try to move my view of you guys so I can start my my video here, and I'll just kind of talk a little bit through what we ended up doing. So you will see some of the imaging here. we'll just review a little bit the coronal, and also I believe we have the sagittal on here as well. And so here's your sagittal view. His pre-op MRI was not great, but at least showed us that it wasn't really extending superiorly. It doesn't connect with the pituitary.
Yep.
So this is a case that we started, and then you'll see when Dr. Ivan comes in to help us out with doing the resection. So this is the tumor, and of course this tumor has already been biopsied because I had done a pretty extensive biopsy to get them a lot of tissue for diagnosis. So you're looking at us clearing everything in really the ethmoid, sphenoid to start exposing the skull base. And as many of you know, the principle when you're doing all of the endoscopic surgery is just to first both debulk so that you can get access, but also get around everything. So you're seeing the septum bulging over, and you're seeing the inflammation in the maxillary there that we've now cleared out. So once we go through the septum, you can see now that there's tumor on both sides. We wanted to try to preserve as much of our septum as possible that we didn't think was involved, but when we finally did get out all of the septum that was involved with this tumor, it was a very little sliver of septal flap. So we knew that there probably wasn't going to be a good septal flap at the end. And then here we're just exposing the ethmoid skull base. We're cauterizing our ethmoid arteries so that we're preparing ourselves for doing our anterior skull base resection. And then the principle is really just getting circumferentially around everything. So now we're looking at the anterior portion, and soon you'll see that we'll drill through and do a full Lothrop in the front so that we can get connection between our frontal sinuses. You can see going all the way back to the sphenoid. And now we really have this floating tumor, and we're just going to debulk it a little bit before we start trying to open up the skull base. And then we'll start drilling down some of that bone so we can get through and expose our dura and then resect our tumor as much kind of in block from the skull base as possible. Even if it's not a classic tumor, I usually like to try to take that piece as one as opposed to lots of little pieces. So you can see the exposure of the dura here.
But Corina, had it gone through the dura?
It was attached on the dura. So this is Dr. Ivan's team coming in here and making some of our cuts so that we could really release the portion of the dura that was attached. And everything else, obviously, we left in place, but it did really adhere to the dura for a small portion of the tumor. And you can see that it didn't end up being as large of a skull base resection. This is kind of like a mini skull base resection, but we did take out all of the dura that was intimately attached to this tumor.
And so you were able to get clear margins?
Yep, I did actually treat this the same way I would treat a squamous cell or anything else. I did margins on everything. So before we even got to this, I had gone through margins, including taking down the lamina where it had eroded through on one side. So here we're just taking out the falc so that we get a really nice area to repair, and then putting in a little bit of Surgicel. We do our repair differently. We often do our repair with alloderms. This is alloderm being spread out. We do an inlay onlay. So I'm tucking all of the alloderm underneath the edges of the bone. And then I'm using gel foam wrapped in Surgicel in little strips to basically tuck in the cavity so that it sits up underneath the bone between the brain and the bone of the nasal cavity. And once you fill that area, then it really does hold everything in place. And you're seeing us just kind of doing that whole process of the repair. And then we really lay everything out. We'll do a Valsalva, making sure that it's nice and watertight. And then for this area, we'll cover everything with gel foam and put in packing, which is what you're going to see.
You see, Luigi, in Miami, all the patients are very svelte. Nobody has any fat on them. So we can't find any fat anywhere.
Nice
they all want it put in their butt. So this is, kind of how we do a lot of our repairs. And this is how we did this patient's repair. This is his post-op imaging. And you can see that we have the alloderm repair here, then the packing that's there, and that we didn't see any signs of residual tumor. And then this is just the 4-month post-op. I saw him recently. He's doing very well. We did not end up doing radiation because his MIRAP was negative. He's back to work. He's doing his regular activities, and he looks pretty good. We're pretty happy with the resection and repair. We'll keep following him with imaging. But this was certainly a strange case, and he is a unique individual to begin with. So I think it's kind of a unique case to take a look at.
So Karina, we should publish this. I have one up in Toronto. It's exactly like this, and yours. Have you looked into the literature? Because I had my fellows look into the literature of malignant craniopharyngiomas in the paranasal sinuses, and very few in reports.
We actually sent genetics, and it came back consistent, just to make sure that we did have what we expected. And so we're writing up the case report, but I think it would be really interesting because there really isn't anything in the literature. Luckily, this patient is very excited to be unique, and he is excited to be at the center of a publication about him.
Corina, you should join forces with Fred Gentili, maybe report them together. It'll be more interesting.
It will be a series.
Yes.
Okay, great. Thank you. Great case. Mike Chacoin, let me invite you to share your slides, please. You're muted, Mike.
Yep. Can you hear me now?
Yes.
Yeah.
Great. Can you see my slides there?
Yes, indeed.
All right. I'm going to talk a little bit about craniopharyngioma here. Let's see. It's not advancing here. There we go. First off, thanks to Jacques and the team there at University of Miami. These Zoom symposiums have been great as we all hunker down during this COVID thing, getting a chance to meet up with our colleagues and continue neurosurgery. Here's Jacques welcoming our Nigerian guest at the NESBS in 2017. I tried to find a picture of Jacques screaming down the street in his Tesla, but I think he was moving too fast.
I have a lot of those. I'll show them later.
Good. I think the Miami-Dade County Police have some of those too, but that's another story. But thanks again. These are great. For some reason, give me trouble.
Hover over your slides. Yeah.
There we go. So here's the case. This is a 39-year-old gentleman with a suprasellar lesion, some headaches, some blurred vision, some mild endocrinopathy, some polyuria, polydipsia, and this lesion here. You can see it on the T2. It's bowing up his chiasm, contributing to his visual field deficit. CT, not a lot of calcium on it. And here's his visual fields, somewhat of a bitemporal hemianopsia. So lots of choices. So in life, just as in surgery, there are choices, there's options. We have the Trump-Biden choices. Some choices are good, some choices are bad. And in surgery, the same, we have choices. So maybe just a quick pull of the panel there. So for this tumor, as you see in the upper left and right, transcranial approaches, endoscopic intranasal approaches, maybe a show of hands or votes there.
So to me, definitely endoscopic approach.
Luigi, endoscopic?
Yes, endonasal.
Yeah, I agree. Me too. Phil?
Yeah, me as well.
Okay.
All right, so we agreed. We did an endoscopic approach. I won't ask you who you voted for in the lower left part of the slide there. But, so here's the video of that. I'll try to skip along through some of it here for the sake of time here. Did this with Patrick Pipcorn, one of my ENT colleagues here. So the initial approach here, drilling off some of the tuberculum and planum region there. I'll skip forward, opening up some of the dura in that region. Starting to see a lesion here. Coagulating some of the intercavernous sites. So you can see the optic chiasm distorted superiorly there, kind of coagulating and shrinking the tumor some. And it was unfortunately rather adherent to the nerves and chiasm, made it a little bit more challenging to deliver this one. It shrink to some degree with the bipolar coagulation, has that sort of typical character of a cranial. See pretty adherent there. And coming into view here, we see the pituitary stalk kind of stretched. And so that question of, do you try to save the stalk or you just amputate the stalk? He did have somewhat preserved pituitary function, not 100%. So wisely or not, I tried to preserve his stalk. Anatomically, it seemed intact. And ultimately, it seemed like we got the large majority of it out, but there was some of it really stuck to the undersurface of the chiasm. And then we closed up here. We happen to use this, in this case, a bi-layer buttonhole alloderm technique, also with some fat. I liked Luigi's description of the cork stopper. So a combination, then a nasal septal flap. He did okay after that. His vision initially, immediately after surgery, was worsened, so concerning. We did this immediate MRI. Fortunately, shortly after that, his vision got much better, but kind of as I was concerned about, there was a little residual tumor there. So what to do now to radiate that or not? But when we saw him a few weeks later after surgery, he was doing well. He did have hypopituitarism, worse than before, so saving the stalk may not have been any great advantage. A little bit of residual tumor there, as I mentioned, and this was a craniopharyngioma papillary type, unlike the one that was just recently described earlier, and it did have the BRAF V600 mutation. So a little time goes by, and he didn't pursue any treatment, and unfortunately, it's coming back. And so, you can see the cyst enlarging, a little bit of worsening of his vision. And so now what? Maybe I can pull the panel there and see, what would you now? A little bit bigger tumor. Would you go endonasal again? Would you do a craniotomy, eyebrow? Would you radiate? And if you'd radiate, what technique would you use, or how else might you treat that one?
So Michael, interesting case, unfortunately, not uncommon story with these cranial, talk about recurrent pituitaries, there's recurrent cranials are very, very common. So to me, I've had this happen very often. And what I do here is it depends on vision. If his vision is getting significantly worse, he needs another operation to decompress his optic and then get on with radiation, right away. If his vision isn't that significantly compromised, I would proceed with radiation now. This is not a good case for gamma knife, obviously, because of the optic. I would do IMRT, fractionated radiation. And some people would say, well, look, it's cystic and it doesn't, radiation doesn't help. That's not true. Cystic components can, in fact, respond to the radiation. I've seen them, collapse down very, very quickly. So that would be my recommendation, based now on what his vision is like. You can't, if his vision is going rapidly, you have no choice but to go back in and decompress his optic apparatus. You're not going to get a total removal, absolutely, the second time around in cranials. That's going to be impossible.
I agree with Fred 100%, and I have seen this, especially the first 10 years of my practice when I would not radiate them. And I have even seen patients who were radiated and the cyst continued to be there. And eventually the day of surgery, MRI showing that the cyst comes down and you don't go in, kind of cancel surgery the day off. But, what opened my eyes was about almost 10 years ago. Mike McDermott and I wrote an article, a review article on craniopharyngiomas and recurrence. And I went through the entire literature from Mallis to now. And the truth is that gross total resection of craniopharyngiomas is associated with up to 50% reoccurrence. That's what we call gross total resection. And that radiotherapy for craniopharyngiomas, even up front or at the later or remnants, is almost 100% control at the 10-year, anywhere, usually above 95%. So that's the data. Now, I've heard this argued so many times, and I'm not exactly sure what data people are looking, but I think really, I do not think there is much of an indication to not radiate somebody post-op, especially somebody who is already hypopit. But I agree with Fred. I wouldn't go in now. I would just radiate it. If his vision's okay, I would. Yeah,
that was my point. But if his vision is going down, and I've had those who've come in, the patient, it says she's now severely, you have no choice. You have to go back in, but only to decompress her, her optic apparatus, that cyst, and then get her on to radiation right away.
And would you do it from above, Fred?
No.
From below?
from below.
So his vision actually wasn't too bad, maybe a hair worse, but you know, for the most part, he was fine. It was nowhere near as bad as it was when we started. And so as I mentioned, you know, it had this BRAF mutation, and our oncologists were a little fascinated by that. So he got started on a BRAF and a MEK inhibitor. And this was the fall. This was a couple months later, maybe a little bit of shrinkage. And then some 6-8 months later, drastic reduction in the size of the lesion in response to these BRAF and MEK inhibitors. And so you see his vision at that point is doing fine. And so at this point now, we did treat him with radiation, but now our target was much smaller. I'm sorry, these images from the Gamma knife don't show up all that well, but you can see it's a pretty small target, and the amount of radiation, you know, to his chiasm and optic nerves was much less. We did this with our ICON device in a hypofractionated technique using a mask with 5 doses rather than a single dose. And here he is now, you know, 3 years or so out from the initial, and has little, if any, tumor left. And so something to think about, you know, here's just the series of it initially. Here's early post-op, in that early recurrence, and then response to the MEK inhibitors, and then same scenario in the coronal. So a couple things. So here's, you know, some of the data from UCSF from some years prior, but you know, talking about how Phil had mentioned, you know, the radiation with a subtotal resection is quite effective, you know, maybe as effective as a, you know, so-called gross total resection. And then this whole idea of the BRAF inhibitors. So, you know, as the Boston group identified that the vast majority of these papillary craniopharyngiomas, 95% or more of them, have this BRAF mutation. The adamantinomatous tend to have the beta-catenin mutations. And they had this early case report from the group there in Boston showing a dramatic response of one of these tumors. And an interesting thing in that paper,
shrink to what you showed. And secondly, would you consider using it neoadjuvantly for a, unresectable or really tough looking, big tumor that, it's a craniopharyngioma, just to make it more manageable?
Yeah, it's an interesting concept. I mean, again, it only works in the papillary variation, not in the adamantinomatous. So, at least probably need a biopsy to confirm you have a BRAF mutation. But it's an interesting concept. Maybe in the future, we'll see what comes out of this alliance trial that's ongoing to see what the role of it may be. But
how long did you treat it for?
He ultimately had, I think, about 10 months of the drug, or the two drugs. And generally it was very well tolerated.
Yeah.
Yeah, very important case. Thank you for sharing it with us and the audience, so they're aware of that wonderful work that started with Priscilla and Fred Barker up in Boston. Phil, take us home. Show us what you have.
Hold on. There we go. All right, so I had to take a lot of the pictures that I was going to share with you because I was told they were inappropriate. It was mostly Jack. And late night.
That's okay.
All right, so just a plug-in for neurosurgery. Now we have a whole section for skull base, and please submit of the Red Journal, and please submit. We're looking for good basic science and serious kind of research papers for skull base to advance it into the world of modern science. In a couple of cases, I'm going to start with this one. It's the second one is a very recent one. This one's a little bit back, but I think it talks about a different pathology that we haven't talked about much yet. But it's a 55-year-old woman with 2 months of trouble with her vision and multiple cranial neuropathies, progressive headaches, and she presents with this. So, thoughts from the panelists?
When you say cranial neuropathy, I'm sorry, which ones? 3, 4, 6, or
3, 4, 5, 3, 4, 5, and 6. 5 is partial. It's mostly ophthalmoplegic, but not completely.
Unilateral.
On the right.
Right.
And no endocrinopathy?
No.
So Phil, this is a interesting, challenging lesion. I think in terms of the differential, I get the impression from the axial. He's got an intracranial component, right?
Oh yeah, even on the sagittal you can
on the
see
sagittal, you see it. I guess just going up, but not as much as the axial on the sagittal. In any case,
yeah,
this could be, I think, anything from a chordoma, chondrosarcoma, very unlikely, but there it could be a paranasal sinus lesion, could be a lymphoma. Difficult.
It's too nicely rounded for a lymphoma, Fred, I think.
Yeah, I think that's very down on the on the list.
Can I ask?
He met at least a cavernous angioma.
Schwannoma.
Schwannoma, yes, very much so. Schwannoma.
Can I, before I tell you my opinion, Corina, looking at the T1 and T2, if you think of paranasal sinus tumors, which ones come to mind? Do any come to mind with this appearance? Ignoring the fact that it's through the clivus onto the brainstem. If you had seen this more anteriorly, what would you have thought of?
I think that it probably depends a little bit. It certainly, it's not real bright on T2, so you're not really thinking of something that, is kind of your classic, so this type of expansion we'll see in some of even the benign sinus tumors. But, sometimes I just think of really extensive adenomas. We've had some very extensive adenomas that have really extended out.
Oh yeah, they're great mimickers, absolutely.
And because of where it's based, it really is so posterior. It's not really in the anterior portion of the skull base. It would be high on my list of things to be thinking about. We've definitely had, you know, huge sinonasal components with erosion of bone and that look like other things. So at least when I look at this, that's something that I'm kind of thinking about just by location. And then obviously the erosion through the clivus makes you think of other things.
You know, Phil, it's not quite well like the ones I've seen, but I don't know if somebody mentioned it, but cavernous sinus hemangioma.
Yeah, that's what I mentioned that, yeah.
Yeah, absolutely. Have this, you can take a pencil, as you know, and draw it around, and they have that typical spilling into the cella. I don't have a coronal to see if it does it, but the ones I've seen, I haven't seen one that's digging into the brainstem like this that far posteriorly, but anyways, it comes to mind.
So Bill said this was something we hadn't talked about yet. So how about adenoid cystic?
Sure. My first thought was a MEK inhibitor or something, but then I thought maybe we should biopsy this, and we biopsied it, and it's chondrosarc.
Yeah.
High-grade chondrosarc. So what would you guys and gals think about? How would you approach this other than the MEK inhibitor?
Let's ask Luigi first. Luigi, what do you do in your center? Staged approach, or what do you do?
Staged, and the nasal and then transcranial approach, yes.
And you would start with the endonasal?
Yes, it's a chondrosarcoma. I think you can go first in the nasal. You can go, no problem.
Fred.
So I'm not sure if I missed something here. Do we have a diagnosis?
Chondrosarcoma.
Oh, I see. Biopsy of chondrosarcoma.
High grade.
High grade chondrosarcoma. Yeah, I think, you know, it's difficult. You can do a combined approach. I would probably, like Luigi, go initially. It's easier, simpler to deal with the endonasal component and see what you can do, but I'm not sure that's going to help, you know, the intracranial component.
Mike Chicoine.
Yeah, I would go anteriorly first. I mean, you know, endonasal, at least in part, but I might, with my ENT colleagues, think of something more expanded, you know, maybe a Caldwell-Luck transpterygoid approach to expand this and get a little broader access. You might be able to get quite a bit out of the middle fossa. You know, these chondrosarcs are often kind of soft, and you're looking with angled scopes and things, you might get a lot of this out. And it's presumably a large majority of it is extradural. It's going to shell off the dura nicely there. So I would definitely start anteriorly.
Phil, you're not showing us a coronal, but I assume obviously the carotid is completely, I mean, the cavernous sinus is exploded.
So I can't use the pointer here, but the carotid, you see that little dot, it's in the middle of the tumor, kind of a centimeter off the middle there, and it's basically the tumor has gone around the carotid and goes out in the middle fossa. The carotid has not been displaced. It's kind of in the middle there where it's supposed to be.
Yeah, I personally would do the reverse of what the guy said. Maybe a year ago, I had a chordoma, a little more midline, but very similar, almost reaching the fourth ventricle. It was splitting the brainstem, and I was worried about the basilar perforators. So I actually went transcavernous, transcranial first, cleared everything intracranially, and I'm glad I did, because I wouldn't have been able to handle the perforators that well endonasally. And then the part that was clival and into the sphenoid was very easy to then do stage 2 endonasal, and then to deal with any CSF leak in the stage 2. That's how I did it. And I think that's—
So where did you stop? Where did you stop anteriorly?
Just at the clivus. I mean, you know, after I did that
kind of where the clivus, okay.
Yeah.
Well,
I didn't want to create the CSF leak from the transcranial operation. I was going to create it in the second stage.
Well, I thought I should go. I agreed with most of you. I should do it endoscopically and see what happens, and potentially go as a second procedure later. And we got in, and I was able to pull all of the tumor out of the brainstem, saw the basilar, saw, in fact, this with an angle scope, the seventh nerve, which was next to the IAC. So we had a big hole. And once I did all of that, I decompressed completely the brainstem. I decided to try to get out laterally. And a lot of the tumor, like Mike was saying, was coming. And this is the only thing for time purposes. And after I got a lot of that tumor out, I kept on having this arterial bleeding. Now, mind you, next to my sucker here is where the carotid is, which eventually I controlled the bleeding, but after quite a while. Now, I had gone out quite a bit with curettes behind the carotid, but I was concerned enough that we packed it, it stopped bleeding. We took it to the angio suite. We found out that, again, I don't have a pointer here, I'm not sure why, but the little thing here up front in the carotid, as it goes straight up here, it's going straight up because the tumor had basically straightened it out. And that little thing medial to it is extravasation. So basically I valsed a perforator off of the carotid itself. So they sacked that carotid. Now, this is the immediate post-op scan. So basically the only thing that's left as far as tumor is concerned is that stuff that was so far lateral, but you can see now where the carotid is, and you can see I was centimeters out from there. And as I was pulling stuff gently, knowing that I'm around the carotid, I pulled something.
You were too greedy. That's what happened.
Yes.
You were too greedy.
That's right. That's right. And actually, you know, listening to you saying what you would have done, although I don't necessarily mind what I did, I think it wouldn't have been a bad idea to go all intracranial, because I think I would have done the same job that way. But, you know, I was lucky that she didn't leave that carotid and she didn't turn anything, and she actually became, her cranial neuropathy improved significantly, and then I radiated her, and this is the scan now. So I was itching and thinking of going in transcranially, but then I realized, and this is 3 years post-radiation, that I'm not so sure that the combined thing would have added anything to this. A second, you know, cranie would have added anything to this, but I started thinking, like most of you did, that the combined thing would be the needed thing, and I proved myself wrong, I guess, in both ways.
But I mean, Phil, I hate to say it, but it's only 3 years and it's a chondrosarcoma. Isn't this residual? Yeah, I mean,
I agree.
Yeah.
But I don't see, I mean, I don't see tumor per se. I mean, maybe in the bone, yeah, but I don't see intracranial tumor, and so yeah.
I think it's an excellent result, Phil. We have to see the long-term thing, and that's the advantage of the endoscopic approach. I don't know if you would have got, you know, the cranial nerve improvement, you know, with an open approach.
True.
So that's, I think, a very good result.
True, but I will also say that were I to cause a big bad stroke from taking the carotid, I would have thought exactly like Jacques was saying. I should have done this all transcranial, and if I need to, you know, if there was something in the clavis I couldn't reach, I would have, you know.
Hindsight is always an issue, you know, but
Exactly.
it doesn't work that way.
Exactly right.
Did you encounter any CSF, or was it all extradural?
No. It was through and through the dura into the posterior fossa. It was a big hole in basically there was no dura there. Yeah. The middle fossa stuff was all intradural. So there was dura, as best as I could tell. And we never, for example, got subarachnoid blood from this. But no, we were clear into the pia. I mean, not into it, but next to the pia of the brainstem. It was in the posterior fossa. It was all intradural.
Excellent.
Very nice. Very nice. Yeah.
Nice.
So this is open mic. Anybody wants to ask questions, challenge somebody else? Actually, you remind me something. Oh, you have another one?
I have another one, but I don't have to show it. I mean, we can open the mic.
Yeah, we just have 5 more minutes. I think I'd better finish it up with questions. Luigi, you quoted in your presentation that ESBS consensus statement about meningiomas of the anterior skull base. I actually used that paper recently to kind of give the counter argument, because we're not going to get into it today, but I don't like endonasal for even simple endonasal, anterior skull base meningioma. But in that consensus statement, it said transcranial remains the gold standard, no? Or am I misreading what's in the paper?
Absolutely.
Yeah.
So so Luigi, let me.
That there are some advantages in selected case on visual function for tuberculum cell meningioma. But I agree, it's different as what happened for craniopharyngioma.
Yes.
Completely different.
No, sorry, Jacques. Jacques, this is the EANS one. I don't think I've seen one. As you know, there's a one out of Pittsburgh that is a consensus statement for endoscopic skull-based surgery that was started there, and the results were similar. And I did one for olfactory groove that suggested that, in fact, the open approach is really still the approach of choice.
Correct.
There's located, particularly anosmia now that we know, anosmia is a very important function. So, you cannot spare olfaction using endoscopic. You can, not always, with an open approach. So very rare indications for olfactory groove meningiomas.
But Luigi, question though. Last time I was with Paolo, he was telling me that he does not do endoscopic stuff for tubercular meningiomas anymore, because I said the exact same thing to him, that I like the transcranial approach too much to not do it. But do you guys still do it, or what do you say practically?
Absolutely, we are doing and we are doing more tuberculum than olfactory groove. We are doing more tuberculum than olfactory groove. And but as I said, the problem for meningioma was the CSF leak rate, because it was some way accepted for craniopharyngioma, high rate of post-op CSF leak, because all the problem related to transcranial approach for craniopharyngioma surgery, but was not acceptable for meningioma, because the result for meningioma, the transcranial result for meningioma were and are good. So when you have to compare the two routes, you have to give at least the same results. And for meningioma was not so good at the beginning. But once you have solved the problem of leakage, which was the main problem, I think that at the end, with the proper indication, you can do this surgery. Also on tuberculum cell meningioma. Because I think that among the anterior skull-based meningioma, the tuberculum or diaphragma are the more difficult. I don't know if you agree, but even not so large tuberculum cell meningioma can give you some problem. Yeah. So the endonasal route with the proper opening can give good result. One, you have solved the problem of CSF leak. This is the reason why we are pushing so much this technique of 3F.
My own approach has been, and I've presented papers on this, that selection is the key, and the issue is what and people have different selection. I must say, in my own practice over the last year, I've done much more open because my selection is very critical. Any lateral extension that you're not going to get a dural margin on that from an endoscopic approach. And so it's the issue is that there is an indication. There's people who say I never do it. I don't think that's right, but it's a careful patient selection.
Absolutely. The key is the selection. I think the most difficult case for transcranial route can be not the easiest case for endonasal route, but some way when you have a deep cella with the flat tuberculum is quite easy to remove this tumor from below. That's all. Of course, what the case we treat usually are not those with the vessel encasement, with the paracellular extension, are strictly midline tumor. So in this case, you can do.
It's true, but also, I mean, you have to confess that we have to place almost a warning label, because there are many, you know, people in neurosurgeons, in community hospitals that go in and they forgot the benefit. We still, I think most of us still believe in the benefit of a low Simpson grade result. I mean, after all. And then, you know, they go in, and I have several cases kind of referred from elsewhere. People even blinded endonasally after subtotal resection from just inappropriate, you know, not people of your caliber or Fred or others, but, you know, that's what the reality can be when they, yeah.
I totally agree, because this is the right message.
Yeah.
You know, we had a lot of improvement and advance with the craniopharyngioma, but when we speak on meningioma, we have to be very careful and honest. I absolutely agree with you.
Excellent.
Okay.
If there are no final remarks, questions from anybody, I cannot tell you how much I enjoyed this session. I'm sure the audience did, and people will come back and listen to the recorded session. Luigi, the first prize goes to you for staying up so late.
What time is it now, Luigi? What time is it? 2?
1 o'clock. 1
Yes,
o'clock.
1 o'clock. 1 o'clock.
It's an early night in Napoli. Come on.
Yeah, that's true. That's true.
Corina and everybody else.
To be with you.
Bye-bye,
All right,
everybody.
guys. Thank you very much.
Have a
Nice to
good
see you all.
Great to see you. Great job, Zach.
Everybody stay safe.
Very
Thanks,
well
Doc.
organized.
Bye, bye.
Bye. Bye.
Bye.